All right, folks, we are live, and I hope you're seeing my screen. Um, and I want to welcome you to our May 2026 St. Luke's and Idaho Clinicians for Climate and Health Learning series. Today we have Mathilde Gaudreau Simard, who is an internist in Ottawa, who will be talking about choosing wisely guidelines, which she has helped to develop and promote throughout Canada. And we're trying to bring to Idaho, as well as other places in the U.S., to help clinicians reduce their reduce their carbon footprint while improving their clinical output. But first, before we get started, I wanted to thank St. Luke's, who is our sponsor for the series, and talk about a few important upcoming events. First and foremost, we're having a second annual Treasure Valley Climate and Health Symposium on Wednesday, September 2nd, and our registration website went live today. So the bluish QR code in the bottom left of my screen, it takes you to the registration page for the symposium. The center QR code is for Idaho Clinicians for Climate and Health's homepage, which I hope you'll take a look at and consider joining. ICCH is a nonprofit that focuses on educating clinicians and the communities we serve about the health impacts of climate change and how we can mitigate and prepare for the future. And our Instagram page is there on the right, that other brightly colored QR code. This week, we are doing a Heat Week event with several national partners, including CDC and NOAA and NIOSH, to focus on heat safety. And tomorrow at the City Hall at the City of Boise, we will be having a proclamation declaring this Heat Safety Week with the Mayor of Boise at 10:30. So if anyone's in town and available to come by, we'd love to see you there. Both our speaker today and myself and Alex Brooks have spoken on Idaho Matters this week. Dr. Gaudreau Simard spoke about her talk today, but that's available on Idaho Matters website from yesterday. And on Monday, Alex Brooks and myself spoke about how the city and Idaho Clinicians for Climate and Health are working to put together a heat safety working group to look at some innovations that we can bring to the Treasure Valley to help keep people safe as our summers keep getting hotter and hotter. And a few other exciting things. As most of you will know, we take the summers off from our lecture series. So there'll be no talks in June and July, but we'll be back on August 29th with Dr. Paul Charlton from New Mexico talking about heat and heat safety with some colleagues from the New Mexico Department of Environmental Quality and Department of Health and Welfare, talking about some great strategies they've implemented in New Mexico to keep people safe. Like we mentioned, we've got the symposium on Wednesday, the 2nd of September. ICCH will be having our fall membership drive and social campaign in October with our date still to be determined. And exciting news that we've got Jonathan Foley, the director of Project Drawdown, one of my favorite climate organizations, is going to be speaking as our keynote on December 2nd. So keep everything open and checked for that. And with that, I'd like to invite Dr. Gaudreau Simard to share her slides, and I'll give a quick introduction. Mathilde is an assistant professor and general internist at the Ottawa Hospital. She holds her medical degree from McGill University and a master's in health sciences from the University of Toronto. She more recently completed a healthcare improvement fellowship with Choosing Wisely Canada and is actively involved in QI and planetary health research. She holds several grants and publications in this emerging field, and finally has led the Planetary Health Task Force that developed the CWC, Canadian Society of Internal Medicine, Climate Conscious Recommendations. So with that, I'd like to welcome Mathilde Gaudreau Simard. Thank you so much.
Thank you so much for that introduction, Ethan. I'm very excited to be here and to share my work. So I'll just jump right to it. So just a bit of a roadmap for the
Mathilde,
talk
real quickly, we're not seeing your slides. If you can just share again, I'm sorry. I think when I shared it, took you away.
No, it's good. This is why we Let me know if it's working. Are they on now?
No, I don't see them yet.
It worked well the first time.
I know.
Because you took over for those
I
few
know.
seconds. Let me do it again. Share.
There we are. Okay, you're back.
Back. All right. So just a roadmap for my talk today. So as those of you who have heard me talk before, I always go through some examples of how I see climate change in my clinical practice. Then I'll briefly talk about something that actually came up yesterday on the interview that I didn't think of thinking about, but just kind of the first project that I did that led me or opened me up to this space. Then I'll talk about the Choosing Wisely recommendations. And then through all of that, I've integrated some examples of local implementation work that we've done, taking those national recommendations to try to do some work locally. Hopefully give you some ideas of things you can do at your centers. So it's interesting because Ethan was talking about a lot of preparedness for heat, and I live in a fairly cold climate, and we actually had an extremely cold winter. We had several weeks in the -30s Celsius. I just did the math. It's -23 Fahrenheit. So it was an extremely cold winter, which has its own challenges when we talk about adapting to our climates. So I work down here in Ottawa. But I also do some work up in northern Canada, in Nunavut, which is the Arctic. And this map kind of shows warming across Canada over the last 50, 60 years. And you can see that there's some regions that are more affected by climate change than others. And the northern part of Canada, part of where I work, has been hit quite hard. And I see that so this is some pictures from when I work up there. So very different environment. It's actually above the tree line, so there are no trees in Iqaluit, which is the capital of Nunavut. And because of the changing climate, they've had lots of changes to their traditional practices. And so hunting and gathering practices, which is really the bulk of how they would get the healthiest portions of their food has been becoming harder and harder. So because of the warming, the ice is thinner, the winters are shortening, there's more accidents as they travel on these big ice areas because the sea actually freezes up there. Same for the animals. The migration has changed over time, and so they're less successful in their hunting practices in hunting caribou. And so although our food guide has been adapted to sort of cultural, what we call country food, which is cultural food, it's becoming harder and harder for them to have access to that. And so they turn to foods that they buy in stores. And because it's a very remote area, it's a lot of prepackaged foods. The rate of diabetes in our Inuit communities are up to 30, 40%. Different reasons for that, including genetic susceptibility, but food for sure is one of the reasons why there's so much diabetes there. And it's only going to get worse in this context. We also now have so Western Canada has had a lot of wildfires for many years. Eastern Canada, which is where I live, it's a very new phenomenon. And so we've seen over the last couple of years kind of longer smoke seasons or wildfire seasons causing smoke that has been linked to increased respiratory admissions and presentations to our emergency departments. New diseases that we're also seeing are tick-borne diseases. This is data from last year. We had over 2,000 cases just in the province that I work. And this year, it's very early in the year, just started seeing leaves in the trees, and we've already had 136 cases of Lyme disease, which is the predominant tick-borne disease that we have here in the southern part of Canada. When I was a resident, which was not too long ago, I had never seen a case of Lyme disease. So this is really a new emergence in the past 5 to 10 years. So I always had an interest in the climate, especially on a personal level. But when I did my master's in Toronto, one of my profs, Karen Bourne, introduced me to this idea that sometimes you can take your personal passions and bring it to work. And the first project that I did in this space was around reducing waste. For our bedside procedures. So as a general internist, I do bedside procedures. And we had noticed that a lot of the supplies that we bring to the bedside are actually not used to during our procedures. And we wanted to quantify that. So me and one of our residents, Alice Yu, did some observations of our colleagues doing these procedures, and we were able to compute that over half of the supplies that we bring to the bedside were completely unused, meaning that they were just kind of taken from the utility room, but not actually used in the patient care. So we did some work around education and reorganizing our procedure carts that led to a reduction in 50% of that waste. So we wanted to go to zero, but it's good to hope. And we accepted reducing to half of our waste as a good success. So it was a very small project, very targeted, but it was kind of our first project that allowed an opening up of this conversation locally. And since then, there's been more and more interest to try to reduce waste around different processes, whether it be things like nursing procedures, so inserting Foley catheters, for example, and just sort of changing our cultures to be more aware of the things that we waste in our clinical practice. And I mentioned this, it came up yesterday on the interview that a lot of people are conscious about their waste at home, recycling, compost, trying to reduce packaging when we go to the grocery stores. But in our clinical care, it's kind of like our brain shifts and we just are so dedicated to the patient care, which remains the most important and central part of our work. But sometimes we forget that small changes in our practices can really reduce the waste that we produce in caring for our patients. And so after that specific project, I started thinking, how can I have more impact? What are the things that I have control over that I can change to try to reduce the waste associated with my clinical care and give some guidance? So there's good studies to show that a lot of clinicians care about the climate and about waste in healthcare, but don't necessarily have the tools to implement change. And so this is a framework that was proposed by a group in the UK, kind of breaking down the different areas of where waste or sustainability for a system can be addressed. So I don't work in primary care, and so that kind of very early upstream work that you see in red here felt a little bit outside of my reach. What really I thought I could impact is kind of matching the supply of health services to the demand. And that goes through ensuring appropriateness of care, so ensuring that the care that we deliver is appropriate and evidence-based. And talking about stewardship, so trying to reduce low-value care, and again, aligning our practices with evidence-based medicine. And so that's how I got interested in Choosing Wisely Canada. So Choosing Wisely has been around for more than a decade. They just celebrated their 10-year anniversary, I think 2 years ago. And as an organization, they're really there to try to help clinicians or empower clinicians to reduce tests, treatments, and procedures that are low value, so either unnecessary, not evidence-based, and don't provide value to patients. And they've had quite a lot of success working with, so really what they do is they work with professional societies. So for example, my professional society is the Canadian Society of Internal Medicine, which encompasses all the general internists in Canada. But they also work with surgical societies, pharmacist societies, nursing societies, and work with them to try to empower the clinicians to have tools to be able to reduce some of these practices. And so it was kind of a natural evolution for them about 3 years ago when they started thinking about, if you're reducing unnecessary tests, you're also reducing the carbon footprint of care. And that's when they launched this Choosing Wisely and Climate Action campaign. They went back to the societies who they've been working with for the past decade and asked them to look at or to revisit recommendations or to make new recommendations that not only reduce low value care, but also have that planetary health or carbon footprint or sustainability lens to it. And so that's what we did on the Choosing Wisely front. I worked on this with 4 other internists from across Canada. This is kind of the process that we followed. So created this working group. We made a preliminary list of recommendations based on our, I guess, content expertise. We made 14 recommendations. We brought it back to our membership in consultation, both a web consultation and then an email survey consultation. We asked them to consider, and I have the principles here, but we asked them to consider the recommendations based on 4 guiding principles: the magnitude of the impact on planetary health, the relevance to the practice of GIM as Canadian general internists, the feasibility of implementing these different recommendations in their clinical practice, and then the strength of supporting evidence. And we did provide some of the evidence with the recommendations. And so went back and forth with our membership to try to make sure that these recommendations were recommendations that they thought were helpful and backed by evidence. And then it went to the Choosing Wisely Canada expert panel for them to review, and that includes patient partners. So it had to have this angle that not only was it good for the environment, but also considered patient preferences. And then ultimately it was approved by Choosing Wisely Canada, approved by the Canadian Society of Internal Medicine Council, and then we then worked on disseminating the work. More recently, we published our recommendations with a lot of the supporting evidence in the Journal of General Internal Medicine, which is how I got to meet Ethan along the way. So in the end, I mentioned that we started with 14 recommendations, and in the end, we ended with 8 recommendations. So I'll go through them here. I'll talk about the recommendations, some evidence behind the recommendation, and then talk about, like I had mentioned, some projects that we're doing locally, looking in our context, how we can implement these recommendations. So the first one is in relation to antibiotics. So the recommendation is not to prescribe intravenous antibiotics for patients that can safely be treated with an oral option, given that IV antibiotics have a higher carbon footprint. So in the past 5 to 10 years, there has been more and more evidence demonstrating that a lot of conditions that we traditionally treated with IV antibiotics are actually can safely be treated with PO antibiotics. So pneumonias, bone infections like osteomyelitis, bacteremias, and even in some instances, infective endocarditis. The carbon footprint of intravenous antibiotics is a lot more than PO, so there are some small studies out of the UK that have looked at this. One example is ciprofloxacin, which the IV version is 70 times more carbon intensive than the oral option. The clinicians on the call will realize or think about the fact that ciprofloxacin is actually highly bioavailable, which means that once you swallow the pill, it gets absorbed to similar levels, or you achieve similar levels in the bloodstream as the IV version. So if the patient is able to eat, swallow, and doesn't have any absorption concerns, then the oral version of ciprofloxacin is as good as the IV version. Because we talked with patients in this process, there's some co-benefits. So patients don't like IV antibiotics. Often patients need to stay in because the reason they don't like it is because they have to have an IV access. Often, and this has been well demonstrated, that patients tend to stay in hospital longer when they're on longer courses of IV antibiotics. There's a nursing burden to administering the medication intravenously more so than oral. And then it also is more expensive from a dollar perspective. So locally, our first question or first condition that we looked at for early transition from IV to oral antibiotics is complicated urinary tract infections. So the IDSA, I guess I say recent, but it's been a year now almost, emitted new clinical guidelines for the treatment of complicated UTIs. And really, guidelines take so long to come out that really what it reflects is evidence over the past five years at least. And so a lot of people's practices had already changed, but really what they did is consolidated some recommendations around length of antibiotic treatment. So 5 days for fluoroquinolones and 7 days for non-fluoroquinolone antibiotic. And then also did consolidate some evidence about early transition from IV to oral, and then changed the definition a little bit of complicated UTIs. The biggest change is that males who we used to consider always to have complicated UTIs are now allowed to have simple cystitis. So historically, we would always treat males longer than females because we always consider them because of the anatomy to be more complicated. But now that has changed. So what we did locally, and we have an electronic medical record, I use Epic at my institution, we were able to fairly easily get a cohort of patients who were admitted with complicated UTIs. Over the span of a year, we were very selective. We wanted kind of the cleanest complicated UTIs. We reviewed 227 patients by chart review. We found that over half of the patients received IV antibiotics for the entirety of their hospital stay. And our median length of stay for these urinary tract infections was 5 days, between 3 and 9 days, which means that patients are getting 3 to 9 days of IV antibiotics, as opposed to having that early reassessment at 48 hours. Interestingly, and this was not something that we expected, many of our patients, so almost 60%, received a longer course than what is now recommended by the IDSA guidelines. So not only do we have some work to do on early IV to PO transition, but we also have some work to do in terms of length of antibiotic treatment. For this subgroup of patients who had bacteremia in addition to their urinary tract infection, they almost all had length of antibiotic treatment that is more than 8, equal to or more than 8 days, despite a lot of recent evidence to say that gram-negative bacteremia treatment of 7 versus 14 days is equivalent. So now that we've realized that we're not doing a very good job, the next step is, first of all, presenting these results to our clinicians, because I think often being faced, and we've noticed this with a lot of our other studies, but being faced with the evidence that you're not doing great usually helps you change your practice. Updating our clinical, and that has already been done, so updating our clinical tools to match these new IDSA guidelines, and then we'll see if that is enough or if we have to do some audit and feedback for our clinicians. Our second recommendation, changing gears, is around heparinoids. So the recommendation reads, don't prescribe heparin or low molecular weight heparin in situations where oral options are effective, preferred by the patient, and felt to be safe by the prescriber. This was actually the recommendation that generated the most both enthusiasm, but also back and forth to make sure that it was well aligned with evidence. So you might be surprised to learn that heparinoids are carbon intensive, and that's because heparin cannot be synthetically made. It has to be extracted from porcine mucosa. Over 1 billion pigs per year are needed to meet the worldwide low molecular weight heparin knees. And each pig is carbon intensive, so 6.1 kilograms of CO2 per kilogram of pig. We don't know to date what happens to the rest of the pigs. So it's very different if the pigs are only used for medical purposes, for extracting of heparinors, or if parts of it are recycled for consumption, for example. But it's very difficult to get that information from pharmaceutical companies. So that the jury is still out as to what happens to the rest of the pigs. So it can be a little bit difficult to calculate the actual carbon impact of extracting that heparin. In addition, low molecular weight heparin, or IV heparin, that is given either intravenously or subcutaneously, involves more packaging, more syringes and needles, as opposed to oral equivalents. Oral anticoagulants are easier to administer and less painful, often less expensive for patients. There's good evidence, again, to demonstrate that patients prefer the oral option over the subcutaneous or IV option of heparins. So that's the heparin. I don't see the chat. I feel like there's probably questions that we'll come back to. So a third recommendation is around metered dose inhalers. And if any of you work in this space, you'll have heard about this, so I won't spend too much time on it. But our recommendation reads not to prescribe gas-intensive metered dose inhalers, where a lower carbon alternative with comparable efficacy, such as a dry powder inhaler, in situations where the technique is adequate and where patient preference has been considered. So the reason we talk about metered dose inhalers a lot in this space is because they're highly carbon intensive. And so in the UK, when they did their national carbon footprinting, 3.5% of the NHS, which is their national health system, was from MDIs alone. So that doesn't count anything outside of that in their health system, but just this one medication was 3.5% of their carbon footprint. And that's because the gas, the propellant that's used in the canister is very detrimental to the environment. And so there's been, over the last 5 to 10 years, more and more recommendations from professional societies that the choice of inhalers should consider climate impact of different inhaler choices, especially that there are alternatives. Actually, in some countries, those alternatives are much preferred over the MDIs. In North American countries, we use MDIs heavily. Interestingly, I gave a talk to a group from Benin in Central Africa about a month or two ago, and they actually told me that MDIs were the only available inhalers. So DPIs, powdered dose inhalers, are not available to them. So it makes it a lot harder, and obviously treating patients is the priority. But when available, they're a good alternative and they're safe for patients. So locally, we looked within our hospital how many of these inhalers we prescribe and use each year. This was a point prevalence study, so at 3 different point intervals. We looked at 30 patients that had been discharged from hospital for a total of 100 patients. And just for those 100 patients, we dispensed from pharmacy 191 metered dose inhalers. So you have the salbutamol and then the Atrovent or the ipratropium. And so each patient almost gets 2 MDIs per hospital stay. And then we were able to quantify how many metered dose inhalers were brought to the bedside and actually not used by the patient. Once brought to the bedside, it belongs to the patient, so cannot be reused for another patient. And that was 66 metered dose inhalers that had no use. When we look at how many doses from the canister were actually delivered to the patient, so you can imagine patient comes into the hospital, they're breathless because of a COPD or asthma exacerbation. They're prescribed this medication on arrival and they get better. They get, a few puffs for a couple of days and then they get better quickly and then they don't need the rescue medication anymore. So we were able to quantify that only 7% of the doses in these multiple dose canisters were used in the hospital. we calculated that we could drive around the Earth 30 times with the waste that we generate with unused doses of these inhalers. So the math, if you flip the math around, 92% of doses are wasted, and a third of the dispensed inhalers were not used. And so the pharmacy team, I won't take credit for this. This was led by our pharmacy team locally, did a few small things. And although like our impact hasn't been, we've started a lot of conversations. We haven't seen a lot of results from our conversations, but we're hoping that as we talk about this more and more, that we reduce our waste. So they added taper-proof stickers on the actual inhalers so that if the patient never used the inhaler and it was still tapered, they could recircle it in pharmacy to try to reduce that waste of unused inhalers. They've also changed their labeling or their policies around labeling in the hospital so that medications that have multiple doses, if they're not completely used in the hospital, patients can actually leave with it. And that's because they had to comply with outpatient labeling that was different than how they labeled it in hospital. But now nurses can actually print a label that complies with outpatient labeling practices so that the patient can take home their inhalers, but also other drugs that we use, for example, creams that sometimes you only use part of the cream and it's still good for the patient to take home. So it's had impact beyond just the meter dose inhalers. We've also done a lot of work with medications that travel when the patient travels in the hospital. So we noticed those 66 extra, or the fact that people are almost getting 2 inhalers per admission, but using very few doses. We figured that there was a black hole somewhere where these inhalers were being lost. The black hole is the emergency department. My emergency medicine colleagues won't mind because that's how they call it. And so, patients often move quickly from the emergency room to the wards, and medications are lost. And so we've done a lot of work with nursing and porters to try to ensure that medications travel with the patients so they don't have to be dispensed when they get up to the ward. The pharmacy team has added terbutaline to the formulary. So terbutaline is the salbutamol equivalent, but it's a dried powder inhaler, so less carbon intensive. And then we've done a ton of education, not just for our physicians, but also for the pharmacists, for the respiratory therapists, for the nurses. And then I mentioned even the porter teams that do the patient transport. So really try to include as many actors that are involved in the care of the patients. So again, we're still working. There's been a ton of work and studies done in different centers that reducing inpatient use of MDIs is very difficult. And that's probably because we often use it because patients come in with exacerbations, and that's really when that propellant is useful clinically. I've had colleagues who've had a lot more success in the outpatient setting, having discussions with patients to try to switch their meter dose inhaler to a dried powder inhaler. And the outpatient setting seems to be more conducive to those switch, and they've had a lot more success than us in the hospital. So this is, I think we're at 4. I don't have the numbers. I think this is our 4th recommendation. Still on the topic of medications. So the 4th one, and this is just good practice and good medicine around deprescribing. So don't miss opportunities to rationalize medications by deprescribing medications whose harms outweigh benefits and/or are no longer indicated during transitions of care when medication reviews take place, with attention to medications such as sedatives, PPIs, proton pump inhibitors, and inhalers like we spoke about. So medications in the breakdown of the carbon footprint of healthcare are really high up there in terms of proportion. It's first of all because we prescribe a lot of it and patients take a lot of them, but also because there's this full life cycle around a pill or a medication that is quite carbon intensive. And so if you think that it has to be manufactured, it has to go to the pharmacy, sometimes they come from quite far away, depending on your supply chain. It has to be prescribed and then dispensed from pharmacy, and often there's lots of packaging involved with medications. Disposal, so we talk a lot about waste, but there's also impact on the environment from the medication. So I was part of a talk last year with a researcher in Toronto, and she's a biologist and looks at the medications in the water, and they can find the most common medication that we prescribe to our patients. So things like metformin and statin, these are minute portions, but they're able to identify these medications in fresh water. And they did these studies in Canada, but I suspect it would be the same in the US. So we use so much of it, and that's also because it's excreted by patients, and then it kind of makes its way to our water. But it has impacts beyond just kind of the waste generated from production. So obviously, medications are great. They make our patients live longer, better, but when it's not necessary, doing sort of a review of medications and ensuring that each medication has a purpose is important. Blood work. So we're changing a little bit from medications. The recommendation reads, don't routinely order daily blood tests on hospitalized patients if it will not change management. So production, distribution, and disposal of the plastic products, so the tubes that we use for blood tests to run in the lab, have a carbon footprint and generate waste. It's been shown that routine blood work, so routine blood work is work that you do on a daily basis on a hospitalized patient without necessarily having a question. So not necessarily saying, I'm wondering if they're bleeding, what is their hemoglobin today? It's more they get admitted and you're tracking that metric every day. It's been shown that it can be avoided upwards of 60% of the time. I have some colleagues who work in the ICU who have done amazing work around this. The ICU does a lot of blood tests to the point where it causes needs for transfusions, which happens also outside of the ICU, but the volume of blood work that is often done without clinical questions in the ICU is really mind-blowing, I would say. In terms of impacts to patients, it can cause anemia. It can lead to the need for blood transfusions, as mentioned, causes pain, bruising, vascular injuries, and sleep interruptions is a big one that we see locally. So our blood work is done between 5 and 6 a.m. when most patients who are in hospital are trying to rest. So often it's what awakes them in the morning is the blood work. It's always also been shown to be quite heavy in terms of health human resources. So you need the blood drawers, you need the lab techs to run the blood as well. So even reducing it by doing it every other day can be really impactful in terms of waste and resource utilization. So locally, we focused on one specific blood test, and that's because Choosing Wisely also has some recommendations specific to particular blood tests. So we focused on serum folate, which actually in certain institutions cannot be ordered on an inpatient. The reason is that folate deficiency in folate fortified countries like Canada and the US is very uncommon. So like our grain is fortified, and so deficiency, if you're eating any kind of grain, is very unlikely. And then serum folate, the test itself is flawed because it varies a lot depending on what consumption you just recently had. So you can be shown to be deficient, but actually have just been deficient very recently. And the other way around also works. If you come to hospital and you eat lots of bread, the folate levels go up pretty quickly in the blood. So you could be chronically deficient, but be normal on the test. So recommendations then where I trained as a resident prior to coming here in Ottawa, we actually would just fortify patients if we thought that they were high risk for folate deficiency rather than measuring a level. So we did a campaign locally on our inpatient wards to try to reduce our rate of folate testing. Our interventions included some education interventions. And then in the summer months here, July specifically last year, we did a competition where we would do an audit of the team. So we work in teams because I'm in a teaching center. The team that had ordered the lowest or the least folate was fed back each week. And at the end of the month, the team who had the least folate orders got a box of donuts that has folate in it. So that worked very efficiently. We saw a little bounce back in September, so we did a bit more education and it came back right down. So we had a significant, and this was like very simple interventions, kind of, we did a retrospective review similar to the antibiotic one that I showed you. We showed that we use it very often, that it often doesn't change management, that deficiency is extremely rare, and that if you're worried about somebody because they have risk factors for deficiency, such as nutritional deficiencies or severe alcohol disorder or malabsorption, then you should be supplementing them. That is the evidence-based intervention. And I hope that this will continue in the same trend. That is the problem with quality improvement projects, is often when you stop intensely monitoring, it often goes back up. Glove use is a pretty self-explanatory one. So this is specific to non-sterile gloves, is to try to only use it when it's indicated. So the WHO has very specific indications for the use of gloves, and mostly it's when you're coming in contact with bodily fluids. So they don't need to be used if you're not coming in contact with bodily fluids or for specific isolation or contact isolation. Inappropriate glove use is unfortunately very common, as high as 42% in some studies. It's actually been associated with patient harms because our adherence to hand hygiene, which is much more effective than gloves, is less when we wear gloves because we feel protected by the gloves and don't always include washing our hands or using sterile gel to sterilize our hands. This is recommendation 7, I think. So 2 more to go. Virtual care. So not to book in-person follow-up appointments when a virtual visit is clinically appropriate and is preferred by the patient. So, I mean, we all remember the pandemic. We did a ton of virtual care during the pandemic because of restrictions with in-person appointments. It reduced patient transport, so emissions related to car rides to the hospital. It reduced the need for inpatient offices, even in the hospital, so emissions related to that. But really, what we also found is that there's a lot of conditions for which virtual care is appropriate. That, you know, there are still studies that have a good fund studying the impact of virtual care in cancer patients. So we know that there are conditions that tend themselves better to virtual visits than others. And so that I think the jury's still out for some of these conditions, and we have to use our clinical judgment. But I think in many instances, virtual care can be appropriate for patients, can be preferred by patients, and also saves carbon emissions, mostly because of the not need for travel for patients and providers. Our last recommendation is to align care delivery with patients' expected disease trajectory and life expectancy. And so those goals of care discussions and really aligning the care the level of acuity of care with what the patient wants and what's expected in terms of their disease trajectory. So in-hospital care is expensive and is carbon heavy. Ward bed less so than intensive care unit beds, which makes sense. So an ICU bed is almost 3 times more carbon intensive than a ward bed. There's a recent study by some colleagues of mine out of McMaster in Hamilton looking at the carbon cost of dying in a community versus in hospital or in acute care. And it was 100 times more to die in a hospital than to die in the community. Studies have also shown that most Canadians would prefer to die at home than in hospital. And so aligning the way that we care for patients with their wishes not only is the best care for our patients, but also the best care for our planet. 2:45 on the dot. Ethan had told me I had 45 minutes.
Nailed it. It's like you've done it before.
Well, this is not my first video.
Yeah. No, that it's just really interesting to see all the simple little changes that you can make in your practice that I think, like you said yesterday and again reiterated today, really add up. And I think one thing that's super important in this work in this space that you kind of touched on at the beginning was that you strive for these huge reductions, right? You strive for the big things, but you can't always hit huge goals. When you're facing those sort of differences between your hopes and reality, how do you position yourself or coach yourself to be satisfied with the difference between perfect and reality? That's something I struggle with a lot in trying to save the world in one go, but the reality is I have this little tiny circle of control that I can actually work within.
Yeah, and I think what I've learned is that often there are benefits beyond what we can measure or realize. And sometimes it's just starting a conversation about waste that'll make somebody think about it. And then, maybe in a few years, we'll implement change in their practice or their personal life. And I think that's true for like climate action, both in your professional life and in your personal life. I think if you get bogged down by the now and this little metric that you're trying to measure in terms of waste reduction, you don't necessarily always feel like you're making a big difference. And obviously, I always say if I was the king of the world, I would have a lot more impact. But I think being impactful in your small circle is more than what we can do, or it is what we can do. Also, physicians have really trusted voices. And so just even talking to communities or to your own community about changes that they can make can also be more impactful than what we can measure.
We had a good question from the audience. Alan Brewington asked that he finds it interesting how patient preferences are often best for the environment. And a great example of the benefits of collaborative patient-centered care. I'm wondering if you get pushback because this would be a major change from most of medicine's traditional paternalistic-based care models. And I think this sort of cuts both ways because I do think I'm an emergency medicine physician. And if patients come to the ER and they don't get blood test or an X-ray or a prescription, they feel like we haven't done something for them. And it's really hard to tell people you don't need that. And so azithromycin becomes the easy way out for so many people to end a visit, which is not good for the patient. It's not good for the planet. It's not good for anybody, but it takes the difficulty out of that conversation. So in a different system, how are you guys dealing with this in Canada?
And I would say it's not just the difficulty of the conversation, but also the time, right? Like we're all getting busier. Our
Mm.
emergency rooms are getting busier as our hospital wards are getting busier. Like you might not have that 30 minutes to sit with someone, hold their hand, and tell them why they don't need azithromycin. The choosing wisely before their kind of climate action did a lot of work with sort of patient facing materials to try to engage them in the conversation. So in primary care, for example, they do have posters around antibiotic for respiratory or for respiratory illnesses, for example, that you can have in your office. And so when the patient walks in, they've hopefully thought about it a little bit more. You know, same for x-rays for back pain, for example, having patient-facing information so that they're prepared for the conversation. In like primary care, you do have more longitudinal relationships with patients, and so you can educate them longitudinally as opposed to an emergency room visit, for example. But yeah, choosing like if you're looking for some of those resources, Choosing Wisely Canada has a lot of resources for patient facing, and that's actually why we also involve them in a lot of reviewing these recommendations so that it makes sense to them, right? And you'll see the wording, like you always have that patient perspective, and a lot of the recommendations were actually chosen were because they patients do like the oral option more than the sub-Q or IV option. So they're really considered in these recommendations.
One thing I found helps those conversations is to, we have a computer in every room, obviously, and I open some guideline. Usually I just use MD Calc, and we'll open like the PCARN head injury tool for kids.
Mm-hmm.
And when parents are, wanting their kid to get a CAT scan that I think is unnecessary, I just say, this is the tool we use to decide things. Let's go through your kid's presentation. So I think having some of these choosing wisely guidelines that we can reference and open in a room maybe makes these conversations a lot easier and makes people see that, you know, avoided care is good for everybody, not just, you don't just want to get a CAT scan, you don't just want to get antibiotics.
Mm-hmm.
But some of those conversations are just impossible. So
And for the
um,
patient too, right? Like there are
mhm.
side effects and like major side effects from antibiotics and from radiation exposure, especially when you're a child, right? So I think which is part of our education that we have to do with patients. But it's not easy. Like sometimes you don't win and that's okay, right? Like that's okay.
You mentioned the Gloves Off campaign, and that is something I'd really like to see us do here, not just because of the carbon benefits, but because, like you mentioned, the improvement in compliance and reduced transmission of infections by doing better hand hygiene,
Mhm.
which numerous studies have shown happens when people don't use gloves everywhere. We did a waste audit several years back, and the ER trash was just all, non-contaminated gloves, just mountains of them. Um, but you did mention in your interview on the radio yesterday about some of the challenges of
Mhm.
instituting your Gloves Off campaign. Could
Yeah.
you talk a little bit about how that process has gone for you?
Yeah, I mean, my message is always work within your circle of influence. I work in a very large hospital. I've been here 7 years, so people are starting to know me. But I have a lot more success when I do interventions targeted to physicians who are my near peers than when the main target is other healthcare workers like nursing and respiratory therapists. And so I think what we learned through this, or like, patient, personal care workers, for example, and yeah, I've had a lot of really interesting discussions with some of my colleagues, almost angrily saying that I don't do the patient care, and so I'm not the one who should be proposing that we use less gloves, and like they feel very protected by their gloves, and feel that when you're spending an hour with your patient because you're doing the personal care, and personal care when there's bodily fluids, of course it's important to wear gloves. But I think I realized that I wasn't the person that this had to come from in order to be successful, and that it coming from our nursing organizations, or maybe our PSW organizations, was probably going to be more successful. So sometimes you can be the face of change, and sometimes you have to know when to not be the face of change. And for that particular initiative, I realized that it wasn't going to be me. It's still something the hospital's working towards. So we have now a small team that does sustainability work within the hospital. So from the administration side of things. So it's something that they're working on at like the hospital level, and that might be more successful. I do talk to my residents a lot. Like I do point of care ultrasound, and people put gloves because there's gel involved, and just like wash your hands. So I do what I can within my circle of influence, but I haven't had as much success. There's been like national campaigns for gloves off campaigns, which I think work well as well. So there's different levels that you can do this at.
I like that you brought up the point of care ultrasound, which was something I was impressed with in your radio conversation yesterday. Um, the idea that we can use POCUS to avoid use of X-rays and CT
Other
imaging.
tests.
And, you know, it's something that I think we talk about a lot, but I think is implemented less often. And you know, I think it's interesting to see how do your colleagues and peers feel about that transition? Like, are other people trained enough in ultrasound to feel comfortable with that transition, or is it something where like
Mhm.
as soon as you go off service, the patient's getting an X-ray every day?
Right. Yeah. No, it's super interesting because that, like, I don't often talk about point of care ultrasound and planetary health together. I talk about point of care ultrasound and stewardship quite a bit because we have had quite a bit of success with some of our projects. So, the one that I've done the most work in is kidney injury. So, patients with acute kidney injury presenting to the emerge and getting a POCUS before they get either an ultrasound or a CT. And our sensitivity and specificity for point of care ultrasound and acute kidney injury is actually really high. And so we did move the needle a little bit on that for radiology ultrasound, because if you find it, you can rule it out confidently. And you can, once you've ruled it in, you just go straight to CT, right? Because the urologist is going to want to know where the obstruction is. And so we've managed to reduce our radiology ultrasounds for kidney injury. For lung ultrasound, I've trained a lot of people locally. For like people are still getting X-rays when they come into the emergency room, but those daily X-rays that we would do on the ward have reduced because we now have a POCUS consultation service. So they'll consult one of us who will have had advanced training in POCUS to look at the lungs and to try to help them discern why the patient's hypoxic. We're like at a critical point right now with our imaging. We're not keeping up with the demand. And so any small thing helps. Like we've actually been asked by the cardiologist to help reduce use of inpatient transthoracic echoes through our POCUS teams because we've gotten pretty good at cardiac POCUS as well. I met someone from I think the Netherlands, who has Choosing Wisely in the Netherlands. And one of their Choosing Wisely recommendations for emergency medicine, and I will dig it out and send it to you, the translated version, is like do not use X-ray in patients who are hypoxic in the emergency room. Use ultrasound first and then go to your X-ray. Like obviously X-ray has a role. Like I'm not saying don't do X-rays ever, but use the ultrasound first, try to see if you know what's going on. And if not, go to the X-ray. So they've actually integrated that because it's just more broadly used, I think, there.
That's really awesome. One other thing I wanted to bring up, and then we'll be at time, and was the discussion about antibiotics. My wife is an infectious disease physician and presented a paper at their sort of little monthly conference yesterday about using dalbavancin in MSSA bacteremia. And it was heartening to some degree to hear that some of the metrics they followed were about patient satisfaction, cost reduction, but had not touched on the climate impacts as much. And you think about something that you're looking at where like you could have a telehealth visit to check in on someone and make sure they're okay, super convenient for the patient to be at home instead of being in a hospital getting IV antibiotics that they may not benefit from, that are going to cost them a lot more money. Our healthcare system is constantly strained, and we could use those beds to house other people.
Mhm.
But it's just the adoption going from a paper that's published where a specialist knows about it to getting the internist and emergency medicine doctors who are the kind of front line of the patient care to translate that into current practice, that I think is a big challenge, but something that I'm really excited about. And it sounds like something that guidelines like the ones you're developing have been able to help people do. So do you have plans for expanding the list or coming out with like a Mark II, the next 8?
I think really like the first, so we have access. It's darbamycin. I've never prescribed it, but our hospital has access to it. And the population that I see it the most in is our unhoused population, where like
Mhm.
IV antibiotics is a nightmare. And they just get a dose and it lasts. I mean, you'll know this better if you recently saw this. It lasts 2 weeks, I think. One dose that they get in the emerge, and then it lasts, I think, 2 weeks. And so it's really, yeah, it's going to revolutionize the way that we treat bloodstream infections for sure, just other infections in those populations and more for sure. I'm very excited for it to be more used. Before we have more recommendations, I want to see that these ones are implemented, like this work has been really meaningful but like you said, I presented this across the country but I want to go back in a couple of years and see if people have, or, chat with my colleagues and to see if people have implemented them and what issues they've had before we give more. Because I think if the list is too long, people won't know which one to focus on. And I think it can be a bit counterproductive. So I think we'll start to see what we can do with these, and then maybe in a couple of years, if I still have energy, we'll do another round.
Yes, I can tell you're an internist, not an emergency medicine doctor, because the ER approach would have been like, okay, we got done with those, do 27 more, then do
That's
27 more. No one ever finished anything, but we started everything.
that's it. Yeah.
So I'm glad you're there carrying these to the completion and making sure that all these great recommendations get implemented. So this conversation has been recorded and will be on our website. I've put some links to several papers that were referenced in the Q&A as we've gone along today. So I hope everyone enjoyed a great conversation about how you can choose wisely to reduce your carbon impact without decreasing the quality of care you're providing to patients today. And I want to give a big thanks to Dr. Mathilde Gaudreau Simard.
Thank you so much for having me.
Thank you, everyone. We'll see you at the end of August, and keep an eye out on the ICCH website for the registration link to our September symposium.